just to remind everyone, inMIND, it was a phase 3 double-blind, randomized placebo-controlled international multi-center trial that evaluated the efficacy and safety of adding Tafasitamab to Lenalidomide plus Rituximab. Eligible patients were 18 years or older with relapsed or refractory CD19 and CD20 positive follicular lymphoma grade 1 to 3A who had received at least one prior systemic therapy, including an anti-CD20 monoclonal antibody. And patients were randomized in a 1-to-1 fashion to receive Tafasitamab or placebo in combination with standard dosing of lenalidomide and rituximab for up to 12 28-day cycles. And in the primary analysis of the inMIND, the addition of Tafasitamab to Revlimid and Rituximab resulted in a significant improvement in PFS with a safety profile that was consistent with the known toxicities in this patient population. And in this sub-analysis, what we were looking at, what we attempted to do was to evaluate the efficacy and safety of the inMIND population with a focus on clinical characteristics and outcomes by age. Specific clinical characteristics we were looking at was in renal insufficiency. So for patients who had moderate renal insufficiency, they were allowed on inMIND, and this was defined as creatinine clearance of 30 to less than 60 milliliters per minute. And for these patients, they were started at a reduced starting dose of lenalidomide at 10 milligrams daily. And what we saw was that, across both treatment arms, in terms of the patient population, 50% were 65 years or older. There were 30% that were 65 to 74 years, and 20% were 75 years and older. So in terms of baseline characteristics, they were pretty even across the different age subgroups, except that the patients who were 75 years or older had a higher proportion who had an ECOG performance score of 1 to 2 as opposed to 0 to 1. They also had moderate renal insufficiency and a FLIPI score of 3 or higher. And then in terms of mean relative dose intensity of Tafasitamab, despite age, comorbidities, the mean relative dose intensity of Tafasitamab was similar across all age subgroups. With respect to efficacy, we continue to see a PFS and a time to next treatment improvement in the Tafasitamab arm compared with placebo in all age subgroups. And so to conclude, for the inMIND study, this post-hoc analysis does continue to demonstrate that the addition of Tafasitamab to lenalidomide and rituximab reduced the risk of progression or death across all age subgroups, and this is including older patients who also had moderate renal insufficiency. And the safety profile was also manageable and consistent across all age subgroups.